Okay, well, good afternoon, everyone, and welcome to Pediatric Teaching. I wanted to talk today about neonatal infections, and when I thought about it, I thought what a big topic it really is, and it covers so many different things, um, risk factors, patients that are more susceptible, the type of bacteria that cause neonatal infections, how to identify children who've got unusual infections, as well as all the intrauterine viral infections and other infections that newborn babies can get. So I thought I'd break it into two parts. And today we'll just talk about suspected serious bacterial infections. So and next week we'll talk about intrauterine viral infections, but there's a lot of overlap in the way they present and the clinical signs they have. So it's good to put it all together, I suppose. So today we're mostly talking about bacterial infections in newborn babies, right? And even that, there's a lot in this. So I'm going to talk a bit about the sort of epidemiology of neonatal bacterial infections, like which babies get it, what bacteria cause neonatal infections at what ages, etc. Then we'll talk a bit about how to detect infections in newborn babies. And I think it's quite hard because many of the features of newborn infections overlap with other problems that newborn babies have. And so we'll talk a bit about how to identify true neonatal infections, and maybe go a bit further than just calling it all neonatal sepsis, but maybe then trying to identify the focus of the infection, whether it's a cord infection or a skin infection or a bone and joint infection or pneumonia, etc. So try to go a little bit more than just calling it neonatal sepsis and treating them all the same. There is some quite useful information I think you can get from a full blood count, and I want to go through that again today. I know I've been through it before, but I think it's really important that we make the most of every test that we have. And full blood examinations have a lot of information on it that might suggest an infection or not completely rule out an infection, but make an infection much less likely. And we just get used to looking at one or two things, but there's lots of different components of the full blood count that we can use to make a judgment as to whether or not a baby has a bacterial infection needing antibiotics or doesn't have. Yeah, we'll talk about, as I said, the types and causes of newborn infections. Today we'll talk about serious bacterial infections, and next week we'll talk a bit more about intrauterine viral infections, the so-called torches infections. There is overlap, but they are a bit different too. So just to go to some very broad epidemiology, we know that of the nearly 9,000 newborn babies that were admitted to special care nurseries in hospitals last year, over half of them had infections, just on half last year, a bit more than half the year before. And the case fatality rate for newborn infections was about 6%. It's been 6 or 7% each year. And so that's the current case fatality rate, about 6%, and 50% of newborn admissions, neonatal admissions to special care nurseries, have some form of infection. They may have other risk factors too, like they might have some birth asphyxia or they might have low birth weight with infection, but at least half have some sort of newborn infection. And I guess in the past we've called it all neonatal sepsis and thought that's good enough, but actually I don't think it's good enough, and I think we should be trying to identify what the focus of the infection is. For many babies, when they first come, you think, I think they've got a likely systemic bacterial infection, and that's okay. But once you've identified that, you should try to think about what sort of infection have they got? Have they got pneumonia, or have they got bronchiolitis, which newborn babies can get, usually not in the first week of life, but a little bit later, and they present differently to children who've got other forms of infections. Have they got an umbilical infection or a skin or a soft tissue or a bone or joint infection? We often miss out urinary tract infections because they're hard to diagnose, but in newborn babies, there's reasons why they may get a urinary tract infection if they've got some sort of renal tract anomaly. And then there's eye infections and diarrhea. and bacteraemia, that is bacteria in the blood, and then congenital viral infections, which we won't talk about today, but can present in a very similar way. So I want to expand a bit more on the, sorry, excuse me. I want to expand a little bit more on the causes of microbial, the bacterial, the microbial causes of newborn infections, because they're a bit different to the causes of infections in older children. And by and large, they're gram-positive bacteria, and typically Staph aureus or Streptococcus, or they're gram-negative infections, particularly E. coli or Klebsiella or Enterobacter or Pseudomonas. Viral infections usually, again, cause one of two types, either intrauterine viral infection, so the baby's born with an infection, or they acquire an infection sometime in the newborn period or early infancy. And that the common viruses causing late newborn infections are RSV, an enterovirus, and a virus called parechovirus, which behaves a little bit like, it makes babies look like they're septic with a bacterial infection, but they're probably not. And then there's a couple of congenital infections that we need to know about. Obviously, congenital HIV, congenital TB, and congenital malaria. So when you think about newborn infections, it covers a lot of different pathogens, and they can manifest in many different ways. So that's just an overview, I suppose, of the types of infections that occur and the microbial causes of infection. It's not exhaustive. There are actually many more types of infections, but these are the ones that I think you need to know about. In the pediatric hospital reporting program, over the years, we've added newborn infections to the program, so that instead of just calling them all neonatal sepsis, we can now be a bit clearer about the proportions of infections that are due to other things like cord sepsis and skin sepsis and neonatal tetanus, etc. So the program asks you to click on one of these, or one or more of these, so that we can be more specific about the types of infections that newborn babies have. Now, when you see a baby that's got a suspected bacterial infection, then there are several types of possible severe bacterial infections they can have. Now, there are many others, because we talked about cord infections and skin infections, and they overlap. But if you think about the three most dangerous infections, sepsis, that is like a bacteria in the bloodstream, or meningitis or pneumonia, they make up the majority of the very serious bacterial infections. As well as that, there are, of course, the cord infections, skin infections, soft tissue and bone and joint infections, which are a form of sepsis. So these all make up the possible serious bacterial infections, but the clinical features of these do overlap quite a bit with other non-infectious disorders. So, babies who have hyaline membrane disease and have respiratory distress syndrome, well, they can look a bit like they've got a serious bacterial infection too. Or babies that are born with birth asphyxia, they can also look like they've got a serious bacterial infection. And many of them do. They may have both a bacterial infection, and they may have birth asphyxia. The point is, there's a lot of overlap between the clinical features of all of these newborn conditions, and also overlap between the clinical features of sepsis and meningitis and pneumonia. So that's why WHO has said that we should think about possible serious bacterial infection, and then try to subcategorize the type of infection into cord infection, skin infection, pneumonia, meningitis, etc. Yeah. Okay. When we think about the clinical features of a serious bacterial infection, there are so many, and many of them, as I said, overlap with other conditions. But if you think that any baby who's got a fever or has hypothermia may have an infection, and if they've got at least one additional sign, like they're unable to feed, or they're drowsy, or they're sleepy or unconscious with a fever, or they've got fast breathing or grunting or severe chest indrawing or cyanosis or apnea or jaundice or severe abdominal distension, or they've got a localizing sign like skin pustules or cord inflammation or swollen hot joints, then they're likely to have a serious bacterial infection. And so I think we need to make it relatively simple so that people can identify the baby who's got a serious bacterial infection. That's fever or severe hypothermia with any other clinical feature of infection. That's good enough to at least consider the baby seriously ill and want to treat them for a serious bacterial infection. As well as that, we've got markers on the full blood count. And again, I wanted to just say that we often look at the full blood count and see what the white cell count is, and we see if it's high or normal or low, and that's all we look at. But there are lots more features of the full blood count that we can look at in more detail, including obviously whether the neutrophils are high or low, or they're abnormally low, abnormally high or abnormally low. And then remember that when the body is faced with an infection, then the bone marrow starts to produce new neutrophils, those often called granulocytes, but new neutrophils. And when it's producing those new neutrophils, then it's producing the immature forms of those white cells. So in the blood film, there will often be immature forms of neutrophils like bands and myelocytes and metamyelocytes. It doesn't mean the child has leukemia, but the blood film can look like that. It can look like, because they've got these abnormal granulocytes in the blood film, it can look very toxic and inflamed because the bacteria are causing the bone marrow to produce lots of new neutrophils. So this is an example of a blood film where there's a lot of neutrophils in this blood film, and two, the neutrophils have a lot of lysosomes. You can tell the neutrophils by their multi-lobed appearance, and they also have a lot of what we call lysosomes, which are small enzymes in the neutrophil that are going to be released into the bloodstream and stimulate inflammation and cause fever and cause sepsis and the features of sepsis like vasodilatation and other things. So the neutrophils are those that drive a septic focus, and they can be very markedly increased, and sometimes they can be, if an infection is so overwhelming that it overwhelms the bone marrow, then they can be exhausted, as in the neutrophil count can drop. And if you see a child who's got neutropenia with a lot of immature forms in the blood, then they've got very serious bacterial infection until proven otherwise. Some of the other features of a serious bacterial infection are if the platelet count is very high. Again, that's just a marker of severe systemic inflammation that can drive the platelet counts very high. And sometimes the platelet count can be very low. And there's another feature on the full blood examination. It's called the red cell distribution width. I've talked about this before, and that is often high when a child's got severe sepsis. And it's often high because the red cell distribution width is the width of the red blood cells, and you'd wonder why that would be abnormal in sepsis. Well, it's partly abnormal because if you've got severe sepsis, then you often have some lysis of the red blood cells, or they'll be deformed and pushed out of shape by the inflammation that occurs in the blood film. And so that's why often the red blood cells are varying shapes and sizes, and that manifests as a high red cell distribution width. It's not a very specific sign, but when you add all these signs up, you can get a good idea from the patient in front of you and the blood film whether they've got a likely bacterial infection or whether they're unlikely to have a bacterial infection. Sometimes the laboratory report or the hematologist report toxic granulation of neutrophils. That's exactly what you're seeing in this blood film, toxic granulation, which just means that the neutrophils have started to produce enzymes that are going to release into the bloodstream to lead to that systemic inflammation. the blood film looks toxic, they say. I won't talk about these other markers, procalcitonin or CRP or ESR. They can be useful, but we don't always have them at our disposal. But if we've got a full blood count that we can get quite quickly, then I think it's a very useful adjunct to our clinical features that we can see at the bedside. I wanted to expand a bit on the bacterial causes of newborn infections, and again, there's a lot of overlap in this, but you can divide it into those that occur quite early, like in the first 72 hours of life, and those that occur a bit later, after 72 hours of life. And so that's been called early and late onset newborn infection. And it has some practical basis, because early neonatal sepsis are always from bacteria that are acquired from the birth process. And so whatever the mother's ecology is, then it's likely to be the babies as well, causing the baby's infection. And early neonatal infection is more commonly associated with, for example, aspiration pneumonia from aspirating infected liquor, or from chorioamnionitis from a pre-existing infection that the mother may have had in the placenta, or if the mother's had a urinary tract infection, or if the mother has been had a systemic infection beforehand, or had malaria, for example, or tuberculosis, then those things are likely to manifest as early neonatal sepsis. Late neonatal sepsis that occurs after 72 hours may also be related to chorioamnionitis or aspiration of infected liquor. It may be, and it just manifesting a bit later, but the etiology is a little bit different. And so we'll talk a bit about that. For early onset newborn infection, when you look at studies that have been done especially in low and middle income countries around the world, gram-negative bacteria predominate. They're the most common causes of early onset newborn infections, whether it's pneumonia or bacteraemia or meningitis. They're the most common gram-negatives, and the gram-negatives that are the most common are E. coli, Erythema, Pseudomonas, Proteus. They're the ones in red are gram-negative, and then there are certainly still some gram-positive infections. So Streptococcus, beta hemolytic streptococcus, which is otherwise called Group B streptococcus, or strep viridans. So Streptococcus and Staphylococcus are the most common gram-positive infections, but gram-negative infections are really common in causes of early neonatal sepsis, and that's why the standard treatment for newborn infections in the past and still currently is amoxicillin and gentamicin. And traditionally, amoxicillin would cover most of these bacteria. Now it covers very few, but gentamicin covers most of these gram-negative bacteria. So it's useful to know the origin of the antibiotics that were recommended as standard treatment for different infections, and the origin of amoxicillin and gentamicin is these bacteria causing early onset neonatal infection. Late onset neonatal sepsis and pneumonia, again, this is a large compilation of studies, many studies that have been done, but as a baby gets a little bit older, then gram-positive infections become a bit more common, and Streptococcus pyogenes, or Group A Streptococcus, Staph aureus, and Streptococcus pneumonia, they're a bit more common than gram-negatives, causing late onset neonatal sepsis. So it's just that distinction between babies that have early onset neonatal sepsis and pneumonia and late onset neonatal sepsis. And it's useful to know where that comes from, how it's the reasons why that might be. Remember, I said if you think about the clinical signs of newborn infections being a baby who has a temperature or hypothermia, a fever or hypothermia, plus any additional sign that indicates a serious infection, and that could be a serious problem with their conscious state or severe respiratory distress, or severe jaundice, or abdominal distension, or localizing signs, that those features would be consistent with early or late onset neonatal infection. I just want to show you some photographs now of these signs. Some of you have seen these before. This is clearly a baby who's got severe chest indrawing. And of course, it could be, like I said, many things. It could be hyaline membrane disease. It could be some congenital lung problem or some airway problem. But a baby who had a temperature of 38 plus that degree of severe chest indrawing clearly is likely to have pneumonia and should be treated as such until proven otherwise. The treatment, the first line treatment for pneumonia and sepsis, as I said, has been ampicillin or amoxicillin. They're more or less the same, or benzoyl penicillin, again, the same to cover gram-positive organisms, and gentamicin to cover gram-negative organisms. Now, if you suspect a staph infection, then flucloxacillin and gentamicin. You should always give, even if you suspect a staph infection in a very sick baby, then it's good to start off with flucloxacillin and gentamicin and then cut back to flucloxacillin if it's proven to be a staph infection. There are many, I'll talk a bit more about multi-resistant organisms a bit later, but now some of the hospital-acquired bacteria are now resistant to amoxicillin and gentamicin. And in those cases, then we have some options, so amikacin, sometimes ciprofloxacin, and then sometimes some other antibiotics that I'll mention. But just know the origin of ampicillin and gentamicin as the primary treatment for neonatal sepsis, and cloxacillin or flucloxacillin, they're the same to add in if a baby is suspected with staph infection. It's important that we have a list in our mind of when to suspect a staph infection, because you don't want to go giving flucloxacillin or cloxacillin to every newborn baby who has a fever. That would be very wrong. But if you keep flucloxacillin and cloxacillin to babies who have some features of a staphylococcal infection, that would be much better. And you all know the features of staph infections, so skin pustules or omphalitis or cord inflammation, like a cord infection, or cellulitis or osteomyelitis or septic arthritis. There, sometimes with some pneumonias as well, of course, are likely to be staph infection. But instead of giving fluclox to every febrile newborn baby, it's important to be able to restrict its use to those that really are likely to have staphylococcal infections. And so this baby, for example, has a severe abdominal distension, and abdominal distension can be for lots of reasons, but maybe you can see that there is actually an inflammation of the anterior abdominal wall. So this baby has abdominal wall cellulitis, and clearly that's likely to be a staph infection, and it may well have originated from the umbilical cord. So again, you've seen a baby who's got a fever or hypothermia and has abdominal distension, then that baby clearly has suspected serious bacterial infection. And then you've got to think to yourself, well, what could the pathogen be? And if you've got inflammation of the anterior abdominal wall, or you've got inflammation of the cord, then clearly that could be a staph infection. And so therefore your standard antibiotics will need to be modified from amoxicillin and gentamicin to cover staph, and that therefore it would be appropriate to give flucloxacillin and gentamicin. So if you see an infant who's got a skin infection or umbilical infection with erythema, then it's most likely to be gram-positive. And I just mentioned before that if you've got a staph infection, then you should think to yourself, is it only in one place or is it in multiple places? So some babies who have staph infections will have multifocal staphylococcal disease. So they may have a staph infection that involves the skin or the underlying tissue like a fascia or muscle or joints or bones, or there might be intra-abdominal spread such as peritonitis. And So whenever you see what you think is a staph infection, ask the question, is it only cellulitis, or could there be something deeper, something more systemic? The treatment, of course, is flucloxacillin plus gentamicin to start with at least, and to get adequate source control. This is another baby you can see has a very inflamed and swollen right lower limb, and you can see that there's redness here. It goes all the way up at least to there. There also seems to be some redness in the suprapubic region, so maybe it goes up even higher. And so this is an extensive cellulitis at least, but you've got to ask the question, is it just cellulitis? Or, because if it was just cellulitis, we might treat it with 5 days of antibiotics and the baby might get better. But in such a baby, you need to ask the question, is it just cellulitis, or could it be septic arthritis or osteomyelitis as well? Because if you only treat that with 5 days or a week of antibiotics, it won't get better. It will just reoccur after you stop the antibiotics. So there are some infections that have to be treated with prolonged antibiotics, but most of them don't. So, but it's important to make that distinction. This is obviously a baby also with a very swollen and shiny knee. And again, you'd be suspecting that this baby had septic arthritis and probably a pus-filled knee. And there was 80 mils of pus in this baby's knee, and it was Staph aureus. So again, doesn't surprise you that septic arthritis or osteomyelitis is often related to Staph aureus. So, and in this case, then you'd start with flucloxacillin and gentamicin, and then you'd modify the therapy based on the bugs that you found. Again, another staph infection that is what's called a breast abscess. It's involving the tissue of the breast in this young baby. Sometimes you see a little bit of swelling of the breast in some newborn babies, which can be just an effect of hormones from the mother, but this is clearly a lot different. There's a lot of swelling around the nipple and very shiny nipples. So this is a breast abscess that would clearly need incision and drainage and antibiotics. This is another baby who also has, you can see, evidence of a staph infection because there's swelling of the umbilicus and erythema of the suprapubic region as well, and the lower abdominal wall. This baby had a lot of pus in the anterior abdominal wall and required that to be drained as well as receiving antibiotics. Again, if you don't drain the pus, then you don't get rid of the infection, and antibiotics alone won't treat this infection. I wanted to talk a bit about skin infections in babies, because we see a lot of babies that look a bit like this. They have these, what we think of as pustules on them. And remember this, we talked about early and late onset newborn sepsis. This is more likely to be late onset neonatal infection. And it typically occurs after 5 to 7 days after the baby's gone home, and the baby comes out in these pustules. And the clue to this being a true staph infection is the pustule here, I think. And because there's clearly pus in it, it's not just a little bit of a red spot, but there's clearly pus, and it's a larger pustule. So if in these babies, if they're systemically unwell, then they need to have systemic antibiotics. They need to have flucloxacillin to start, primarily flucloxacillin to treat their staph pustules. If they've only got a few pustules and they're not very unwell, then often they can be treated with some topical antibiotics or cleaning with soap and water or using gentian violet paint, again, if they're not very unwell. And then you've avoided giving antibiotics to a baby. They don't all need to be treated with intravenous antibiotics. Sometimes they can be treated with local treatment and some oral antibiotics. That's often plenty. I want to just show you some other skin conditions that can resemble staph infections, because I think we see a lot of skin rashes in newborn babies, and some of them are serious bacterial infections, some of them are other sorts of infections, and some of them are not even infections at all. They may be just hormonal changes that occur in newborn babies or other features. So, for example, this is called Erythema toxicum. It's very common in newborn babies, and we might look at it and say, oh, it's probably a staph infection, but actually it's not an infectious disease. It's not infective at all, and it's just, you can see some little pus. There's not a lot of pus in any of them. They're not big pustules or anything like that, and they're usually on the nose and the face, and it's called Erythema toxicum. It's usually a hormonal condition that will resolve by 2 weeks of life. And so if the baby's not unwell, if they're a well-looking, thriving baby, and they're feeding well and not febrile, then they don't need to be treated with systemic antibiotics at all. This is another not problem, but another feature of newborn babies. Is very common in newborn babies. About half of all babies will have this tiny little white spots. They're often called milk spots. They're just due to an accumulation of sweat in blocked pores in the skin. Most of them, that resolves within 4 weeks, but it does look different. These are just what it's called Miliaria, which is, it's different in appearance to Erythema toxicum. Miliaria. It doesn't look as infected as what Erythema toxicum does, but even Erythema toxicum is not staph skin sepsis like this, where you've got larger pustules. Right? So there is a way to make a distinction between these. And then this last one is, I think, is quite hard to make a distinction, but this was published recently. There is a condition called Cophalic pustulosis, which again we'd look at it and say, well, it's likely to be a staphylococcal infection or likely to be a bacterial infection, and we'd probably treat it with antibiotics. But actually it's due to a overgrowth of a fungus. And if you take a swab of it, you can see this swab has been looked at under the microscope, and you can see both fungal spores and you can see the hyphae. See, the hyphae is the longer strand of fungus. So this looked at, this is a wet preparation under a microscope, and this proves that this Cophalic pustulosis is due to a overgrowth of antifungal. And this baby, it looks very severe, but this baby only needed a topical antifungal cream to treat this baby quite well. So as you can see, all of these things look a bit the same, and sometimes we have to try to make that distinction between staphylococcal infection and something that's just hormonal and something that's just a normal phenomenon in babies, this having blocked pores, blocked sweat glands, and something that's a fungal infection. Again, so the features do look a bit the same, but you can make a distinction sometimes. I wanted to, so that's all about gram-positive infections and about skin infections in babies. I wanted to say something about gram-negative septicemia, because most of the rashes that I've shown you have been red in nature, erythematous in some way. Gram-negative septicemia, if it's due to any of those gram-negatives I mentioned, like E. coli or Pseudomonas or Klebsiella or Enterobacter or Erythema, if you get gram-negative septicemia, they're more likely to present with purpuric spots. And this was a baby who had severe Pseudomonas infection, and it could be just like a baby who's got Neisseria meningitidis, meningococcal disease, but that doesn't occur in newborn babies, but other gram-negative infections do. So if you see a baby who's got these sort of purpuric spots, then think about gram-negative infections. You can, like in this baby, we just took a little aspiration of the purpura and look at it under a microscope with a gram stain, and you can see lots of gram-negative bacilli consistent, and that grew Pseudomonas. So that is one way you can identify the cause of these infections. Just remember, purple spots, purpuric spots, of course they can occur if you've got a coagulopathy or if you've got thrombocytopenia, but if you've got purpuric spots in a baby who's got a temperature or hypothermia and any other features of severe suspected bacterial infection, then you have to think that they might have a gram-negative infection, and therefore cover them with antibiotics that would cover gram-negative infections. So again, ampicillin and gentamicin, so gentamicin to cover the gram-negative. Or if you think that the baby might have a multi-resistant infection, then need to think about other antibiotics. This is, and finally, another gram-negative infection that's quite common in small babies. I'm sure you've seen this before, but this is gonococcal ophthalmitis, isn't it? Now, there are many different causes of eye infections in newborn babies. So chlamydia can cause an eye infection, Staph aureus can cause eye infections, but gonococcal ophthalmitis looks like this, where you've got lots of pus draining from the eyes, and these babies need treatment with ceftriaxone, and usually a single dose of ceftriaxone will be sufficient. Sometimes a couple of days is required for if it's very severe, and some topical antibiotics to the eyes as well. But usually they are treated quite well. It used to be that we could just give penicillin, but most Neisseria gonorrhea are now resistant to penicillin. That's a very important thing to remember. That it's no longer, penicillin won't work, amoxicillin won't work. These babies who've got purulent conjunctivitis need ceftriaxone to treat their Neisseria gonorrhea. So that brings us to when to suspect multi-resistant organisms. And this is very hard, because if a baby comes in from the community, then they're likely to have born in the village, then they're likely to have a community-acquired infection. It doesn't mean it won't be a multi-resistant organism, but to begin with, usually our standard antibiotic therapy will be enough, amoxicillin, gentamicin, or flucloxacillin and gentamicin, if we think they've got a staph infection. But if they've been in hospital for a long time, and if they've got other risk factors for multi-resistant organisms, like they've got malnutrition or some form of immunodeficiency, or they've had very prolonged antibiotic exposure, then you need to think about the possibility that they might have a multi-resistant organism, an MRO. And I always try to think about it in babies that are not improving on first-line antibiotic therapy. So you put them on amoxicillin and gentamicin, or flucloxacillin and gentamicin if you suspected staph, but still they remain febrile and unwell with some other sign of serious bacterial infection, and they still have inflammatory changes on their full blood. So if you think that a baby's not getting better after a few days of standard antibiotics, then do another full blood examination and see what's happened to that white cell count and the neutrophils and whether or not there's any more immature granulocytes in the peripheral blood. If it's still a toxic blood film, then that's a good indicator that you haven't quite got on top of the infection yet, and it might be related to either one of two things: you haven't been given the right antibiotic, or you haven't got adequate source control, or because there's a multi-resistant organism. So I want to just say something in the final sort of moments about prevention. And I think it's important that we understand why certain things prevent newborn infections. And you'll hear a lot about early essential newborn care preventing infections, and it's important that we understand why that's the case. You know, why would skin-to-skin contact with the mother and early breastfeeding and not separating the baby from the mother, why would that result in much lower risk of bacterial infections in babies? Well, it does. And the reason it does is because if a baby is born and stays, when a baby's born, they're almost sterile. Certainly the gastrointestinal tract is generally sterile to start with in the first moments after birth. Their skin will be colonized with the bugs that they acquired through the birth process, but their gastrointestinal tract will be largely sterile. But if the baby stays with the mother, then they're likely to acquire the mother's healthy bacteria, lactobacillus and bifidobacterium. They're particularly especially if they breastfeed, getting lactobacillus from the mother for if a baby breastfeeds, and they're less likely to acquire the the hospital bacteria, so multi-resistant enteric gram-negative bacteria. And that's the reason why babies who receive early essential newborn care have much less chance of getting severe bacterial infections, and babies that are nursed with their mother and not nursed in a special care nursery where there's likely to be multi-resistant organisms are much less likely to get a nosocomial infection. Obviously, we have to have very strict hand washing and other basic infection control measures, but I think it's important that we all, as pediatricians, understand why ENC is such an important method of preventing infections in babies. I want to lastly say something about antibiotics in newborns, and there's emerging evidence that, of course, antibiotics are necessary in newborn babies if they have a serious bacterial infection, but there's increasing evidence that antibiotics also have a bad side as well. And the bad side is the change that occurs in your gastrointestinal tract when you're exposed to prolonged antibiotics, not just 1 or 2 doses or 48 hours, but prolonged antibiotics. And prolonged antibiotics lead to the colonization of the newborn's gastrointestinal tract with pathogenic bacteria that are likely to be invasive, like gram-negative infections and Staph aureus, rather than the protective bacteria that come from the mother. So when, as I said, a baby's gastrointestinal tract, their microbiome is sterile at the time of birth, usually close to sterile, and then within a few hours or days of life, they acquire bacteria in their gut. And if they acquire healthy bacteria, the lactobacillus and bifidobacterium from their mother, then they're less likely to get a spread of those bacteria across the bowel wall into the bloodstream and into the lungs and other organs. So that's why if you give prolonged antibiotics, then it reduces the chance of them being colonized with healthy bacteria. And also there can be fungal overgrowth also of the gastrointestinal tract. So you can have a bit more of certain fungal elements within the gastrointestinal tract, and that can lead to serious problems later on. So we should really try to avoid prolonged antibiotics in babies that don't have a serious infection. And you can do that, I think, by having a process by which it's not wrong to start antibiotics. There's nothing wrong with starting antibiotics, but you should try to cease them after 48 hours if the baby's well, and if their full blood examination is normal, and if their cultures are normal. Now, we can't always do all of those things, but you need to make your judgment. You should review all your antibiotics at 48 hours and cease them or scale back to oral amoxicillin, and that's a highly effective way to treat bacterial infections in babies anyway. You shouldn't give any more than 10 days of antibiotics in total, unless the baby's got meningitis, then obviously they need more, but usually 10 days is enough for any even bacteraemia. And for some infections, once you've drained the pus or you've cleaned the skin, then 5 days is just enough. And part of the reason for having a restrictive policies about antibiotics in newborn babies is that there's now good evidence that prolonged antibiotics in newborn babies also lead to other flow-on effects of changing of the microbiome in the gastrointestinal tract, including a longer-term risk of asthma in infancy and older childhood. And so we don't always realize this, but when we start antibiotics, it's okay to start, but just try to then review and reassess and see if the baby still needs antibiotics after 48 hours. If they do, then that's fine, carry on, or change to oral amoxil. But if they don't, then scale back or cease the antibiotics, and that will be good for the babies. More time with the mother, more time acquiring healthy bacteria, less likely to get multi-resistant organisms, and less likely to have long-term consequences like wheezing or asthma. Now, that's all I wanted to say today. I hope that's useful. So we've covered a lot of ground in terms of newborn infections, mostly about serious bacterial infections. And next week, we'll talk about intrauterine viral infections and some other some other infections in newborn babies. But I think as pediatricians, we should be experts in this topic. And so I hope that's been helpful to you today. I'm happy to stop there and see if there's any questions. Thanks.